aim is to look at bladder and kidney cancer. Now, in the first session, we'll look at bladder cancer and very critical questions on bladder cancer. Variant histology, what is the role of resection, really? Is it changing? And looking at also the guidelines, the updates of the guidelines, what has changed? How can do a better lymphadenectomy? The second session was really on kidney cancer. That means clinical T1B, surgery, partial radical nephrectomy, cytoreductive nephrectomy. What is its role in the new drugs that we have today? And the third talk was really on sequencing of metastatic renal cell carcinoma. In the afternoon, we're going to look after the lunch break. It's going to be immunotherapy and how it's dramatically changing our world in bladder and kidney cancer. And the last session, one of my favorites, a rare disease, but an important disease, is upper tract urothelial carcinoma. Role of neoadjuvant, adjuvant cancer, chemotherapy, and so on. When is surgery indicated, and conservative management. And we're going to end up the day with a visionary talk of Professor Zielinski on what is the future of personalized medicine, how it is evolving in oncology. And that's, I think, a little bit running up everything we see.
Today my talk focused on radical versus partial nephrectomy for larger tumors, and I think we have to be very careful when we make our recommendations, and I think that things are not really as black and white as everybody wants to make them sound. And I think a lot of factors go into that decision, including patient characteristics, tumor characteristics, surgeon experience, etc., and so I think it's a very complex decision that needs to be heavily vested both by the doctor and the patient.
The main message is that this aggressive disease deserves a multimodal approach, trying to combine radical cystectomy with other therapies that we will know if it's immuno-oncology, immunotherapy, but the combination is the secret to achieve better outcomes.
Now, in urology, we are always strong followers for everything that is really new. So, at the moment, conservative management for upper tract tumors is very popular. It's very attractive. In my presentation, I will focus on the fact that we maybe should look more carefully on the data that we collect. We should collect them in large data sets prospectively and evaluate them soon so that we can value properly if conservative management has a role in our treatment armamentarium, or that we should go back to the gold standard, which is offering nephrectomy, and in very selected cases, a conservative treatment.
My talk will be focused on muscle-invasive bladder cancer. This is something where the revolution is ongoing in the way we treat patients, because now we have many clinical trials to consider for patients, including immunotherapy trials or targeted therapy trials, and then we are the tools to probably better select patients for the right treatment, for the most effective therapies. It is something that is totally new, that was not available until very few months ago, and so clinical research is rapidly evolving this disease. I would try to summarize the major steps that we have achieved in this area.
Actually, I'm involved in a debate in kidney cancer, in T1B, which is still a localized stage, and the controversial point at this moment is, if we have this sort of tumors based on size, do we have to take the whole kidney, or do we have to try to do a partial nephrectomy with the intention to preserve at the maximum of the renal function?
So the new topics we discuss here at this meeting is, from my perspective, immunotherapy, which is a great breakthrough in general oncology, but especially also in kidney cancers and bladder cancers. So we've learned recently that immunotherapy works in these tumors, however not in all patients. And what we are trying to work on at the moment is to figure out which patients will profit from these treatments and which patients will not.
So in my field, I'm working on kidney cancer. We have seen the advent of immunotherapy in the last 2 years, and we have noticed that about 40 to 60% of these patients do not benefit, while others have an immense benefit. So what is currently underway is a number of studies that are looking at combinations, and these are combinations that would address escape mechanisms. And so this is very important and a big breakthrough actually in kidney cancer.
Well, I think that the novel agents, including immunotherapy, of course, is one of the most important topics nowadays in the treatment of bladder cancer and renal cell carcinoma. Just to talk about GU cancers here. And the development of those drugs is important. We have monotherapies right now, but combinations are upcoming, and in particular for bladder cancer, I think it is important to discuss how to better combine and how to improve the efficacy of the novel agents and immunotherapy.
I think these meetings are exceptionally important, as I think participation in major meetings are more rare, less support by companies to participate in bigger meetings. So I think bringing the knowledge from the big meetings to the local providers, to the local healthcare involved people, the researchers locally, and making them aware of what is happening worldwide, what is the new progress, what are the innovations, how should we change our care, how should we go in the future about delivering the optimal care for each individual personalized patients. That can happen at this meeting. Now we're looking at 200 people. We don't want it to become bigger than that at all. Why? Because it's interactive, it's personal, friendships are built. The interaction is very fast, reliable. People can exchange their ideas. You can really feel the expert. You can sit with the expert, talk to him. Yesterday night we had a Meet the Expert dinner where we had over 140 people getting career advice. All this is only possible if you're small, slim, facile, and interactive.
I believe that the most important person in this meeting is Professor Shahrokh Shariat. The most important thing for me that he, invited very, very good faculty, very professional urologists, uro-oncologists, and very professional staff. And he also, organized them in very new topics in uro-oncology, and this is important that in this meeting we heard a lot of new onco-urological questions, problems, the positions, strategies, and this is very important.
I think this is a very important meeting because it's important that urologists, medical oncologists and other disciplines work together to bring out the maximum for the individual patient.
For me, meetings like these here are much more attractive. So if you manage to bring together 200 people, 250 people, I think you got a more successful meeting than a meeting where you bring 2,000 or 3,000 or 4,000 people together.
It's of course better to deal with small meetings, small dedicated meetings, because they allow us to focus more deeply with the two problems of the different aspects of treatment, of management of patients, of the disease, of clinical trials. So even in a big conference like ASCO meeting or ESMO meeting are developing small thematic congress focused on specific disease, focused on GU cancer, focused on GI cancer. So this is clearly the future.
Well, this is, you only have to look at the name. B2B, it means bench to bedside. So what Shahrokh and the people which is organizing what they have been achieving is a sort of an integrated meeting which you have a part of basic science research, and they just apply this to the daily current practice.
Meetings like this are bring the brightest and the most motivated people together, and I think this is a melting pot out of which I think ideas and collaborations arise.
This is a very, very nice initiative coming from Professor Shariat, and I'm really happy to be here because I think that these initiatives help us to improve the care of our patients.